So thank you for asking me to come and speak today. It's a pleasure to be here. I've not been to a TOFS conference before, so it's great to finally make it to one. So we're looking today at esophageal atresia, Tracheo-Oesophageal Fistula. What have the lungs got to do with it? How are the lungs impacted by a condition that is about the feeding tube? So first of all, we're going to have a look at some population statistics, moving on to look at the ways that the lungs can be involved, touch on the management of these conditions, and finally look at some of the data that we've got from our experience at Alder. So symptoms in childhood. One of the reasons why this is such a difficult issue, and I think most people in the room will have had issues with respiratory problems, will have had common respiratory issues, and when you go and seek out help in primary care, it's not always recognised for what it is. But additionally, respiratory problems are really common in the general population. So this is a population study looking at the whole population, not looking at those with OA TOF, but looking at the paediatric, the children population, and almost a third of children, it's reported that they wheeze. 17% have asthma, but nearly a third will wheeze, which isn't always to do with asthma. 15% are described as having reflux. Over a quarter have a nighttime cough. It's a fifth of children have frequent colds, and nearly 3/4 will cough when they have a cold, and nearly a third cough without cold. So when these respiratory symptoms are so common in the general population, how do you tease out what is a normal childhood illness and what is due to the OA TOF? And to be honest, that's the billion-dollar question, and it can be quite tricky. And that's why it's really important to have specialist teams involved to try to help make this differentiation. Because what we don't want to be doing is we don't want to be over-treating children who are just having, or adults who are having, normal childhood illnesses. So why are people with OA TOF more impacted than other people? Well, one of the issues is tracheomalacia. We've seen some lovely pictures in the last talk of the trachea, the main windpipe, the main breathing tube. It's difficult to say exactly how common tracheomalacia is, where you've got a floppy windpipe. Probably most people have this to some degree. One study found malacia in 83% of their patients, so nearly everyone had some degree of malacia. Another study said just 15% of their population had malacia, but nearly all of those needed treatment for it. And so it depends what study you're looking at and what they have counted as malacia as to how many people had it. But in reality, I would say to some degree, most people do. What is malacia? Well, you've got a weakness of the cartilage that forms the trachea. You've got a weakness of it. And therefore, because you've got that intrinsic weakness, the way that these children who go on to adults are made, the cartilage is weak. And then at the site where they've had the fistula, you've got no cartilage there because you've had something connected to the esophagus. So you're missing the cartilage. So that causes this malasic segment where the front and back walls of the trachea collapse down. We've got some pictures here. So that is a trachea. And so this already, how do I get the pointer? No, not that. Top one. There we go. So this is already quite a small trachea. It's meant to be nice and open. You breathe in through it, you breathe out through it, and that already is quite small. But when we come to look at that one, that's exactly the same. You can see on the right-hand side, that front wall has met that back wall and it's completely closed down, making breathing quite difficult for this child. And so this is quite severe malacia, but what's the problem with it? Well, for some, no symptoms. Some people can have malacia, you don't necessarily know about it, you're having a look for some other reason and it's there. So for some, they'll have no symptoms. For others, there will be the typical TOF cough. The TOF cough comes because your airway is malasic, so that barking sounding cough. It may cause an impairment of being able to deal with the respiratory secretions. We'll come on to talk about respiratory secretions a little bit later on, but we all have secretions, fluid in our airways, that keep our airways nice and healthy. And if your airways are floppy, then you can't deal with those respiratory secretions as well. It can make that you have a delay in recovery from infections because you're not able to clear these. When you've got infections, you can't clear them from your airways as well because the airways are just generally kind of floppy. And in the more severe end, you can have episodes where the child becomes blue, floppy, very pale, these cyanotic episodes, or even in its most severe form, the child who can't come off the ventilator after their operation because their airways are so floppy. So what do you do about it? Well, if it is very severe, you may need some surgical management, an aortopexy. Some people will have heard of a tracheopexy, where you're attaching the back wall of the trachea to something else within the chest to stop it from collapsing down and meeting the front wall and keep it open. A tracheostomy, where you put a tube in so the person breathes through a tube in their neck rather than normally through the mouth and the nose. Airway stenting, where you can put a stent in to keep that floppy bit open if it's only part of the trachea that is collapsing down and causing the problem. Or we have medical management as well. So optimize airway health with antibiotics, with physiotherapy, to really keep these airways nice and healthy as much as is possible to stop the impact of that malacia. Sometimes you'll need some ventilation. Children or adults will need some air being blown into the airways to keep them nice and open, hopefully only at night time, because that's much easier to deliver than if it is day and night. Much easier to run a ventilator when you're in your bed at night than having to take something around with you when you are mobile. So malacia, lots of different problems that it can cause. Aspiration. That is another big problem that we see in OA TOF, and there are different ways that you can aspirate. Aspiration really means food, bits of food or drink, or even oral secretions going into the airway, things going into the airway that shouldn't be there. And then what happens is that once you've had those bits and pieces that go into the airway that shouldn't be there, your body, your lungs recognize that they shouldn't be there, and it tries to get rid of them. So your body says, oh, there's something here that shouldn't be here, and it mounts a response. It sends cells to that area. It produces extra cells, it produces extra fluid to try to get rid of this thing that it's recognized shouldn't be in there. So it's not really the food and drink particles that go into the airway that cause the problem. It's your body's response to it that is the problem. So your body has all of those things that is making loads of secretions to get rid of it, giving rise to that rattly, wet sounding cough. So there are different ways that you can aspirate, and that can be an anatomical reason. So if you've got a stricture where you've got the joint between the top part and the bottom part of the esophagus, as we've seen in the last talk, you can have at that joint side, it becomes tight, it becomes narrow, and secretions, food, drink can gather at the top of that narrowness and spill over into the airways. Vocal cord paralysis, so either your vocal cords are not working correctly, or at the end of surgery, during surgery, you can have damage to the nerve that supplies the vocal cords. And if the vocal cords are not working, that means that when we swallow anything, your swallow is not safe. When we swallow everything, we have to make sure that we close off the hole to our lungs and that everything goes down the hole to the stomach. They're right next to each other. And so it's very easy for food and drink to go down the wrong way, for secretions to go down the wrong way. And your vocal cords are intrinsic, they're really important in closing off that airway. So if your vocal cords are not working, you're going to have food and drink go down the wrong way. Again, you've got a larynx at the top part of the airway, and OA TOF is associated with clefts, holes in the larynx. So even if you do close off your airway, if it's functioning correctly, but you've got a hole there, your secretions, food, drink can go down that hole in the larynx and getting food particles into the airway. Most people with OA will have a TOF, which will have been ligated, kind of repaired at birth. But that could be current. It could open up again. There could be one that was missed. Maybe there were two in the first place. And then that can cause a problem if that's not recognised. This here, you can see, this is a CT scan. This is to orientate you. This is the back, the spine, the arms on either side, and these are the lungs. This here is your esophagus, which is already quite baggy. That doesn't look like a normal esophagus. It's bigger and baggier than it should be. And this is your trachea, your breathing tube. And if you can see, there is a connection between the two. And this young person was around 10 when this was discovered, because this was a second fistula that hadn't been recognised in the first instance. And the symptoms got much better after this was operated on. So going back, as well as the anatomical cause of aspiration, you've got functional causes as well. Gastroesophageal reflux is really common. We've heard from the last talk, it's not just a tube going from your mouth to your stomach where food and drink fall down, but it's got to move down in a nice coordinated fashion. And it's meant to stay down in the stomach. And if food and drink come up, it can spill over into the airways. Dysmotility is really common. Just like most people with OA TOF will have some degree of tracheomalacia, most people will have some degree of a dysmotile esophagus, where the moving the food and drink down the esophagus just doesn't work quite as effectively as in those without this condition. And if the food and drink isn't being moved down as effectively, it hangs around for longer in the upper part of the esophagus and can spill over into the airways. So aspiration is a really big part of respiratory health. This is another way you can have problems with respiratory secretions. This here, you can see this is a scar site. Where's my pointer gone? So this is at the bottom of the trachea, going into the right lung and the left lung. And this here is the scar site where there was a fistula. This was the tracheal side of that tracheoesophageal fistula. Oops. There we go. And it's the same airway, but this is taken now as the child is breathing in, and that has opened up. Now that isn't a fistula, that doesn't go anywhere, but that is a pouch, or a diverticulum we call it, within the trachea. So that is left over from the surgery, and secretions can pool within there. They can become retained, and that's really difficult to manage. Those secretions can become old, they can stagnate there, and a lovely breeding ground for infection to develop. Oops, too far. This is a really busy slide, and this is intentionally so, because when we think about respiratory infections, there is not one thing that makes children and adults with OA TOF more prone to respiratory infections. There's lots of different things that lead in, and they all lead into each other. So we have weakened tracheal cartilage from the way that made part of our malacia, along with a narrow airway lumen. So these malacia, they mean that we have a less effective cough. When you do cough, it sounds like a really loud cough often when people with OA TOF cough, but it's not necessarily that effective because of this malacia. It doesn't move things out of the airways as effectively as it should do in all cases. The air is not clean. When we breathe in thousands of particles that shouldn't be there every day. And the point of our respiratory tract and these respiratory secretions is to move them out so they don't settle in the airways and they don't become infections. We're all breathing in particles, viruses, bacteria all of the time, and we have to breathe them out as well. So if your airways are floppy, if you have loads of secretions, then your airways can't get rid of these particles as well as if they weren't there. So you've already got less effectively able to move the secretions around. You've got more secretions. And when you've got a virus that does hit you, then you have even more secretions, and it's just very difficult to deal with it. So it's really common to get viral infections. And then when you've got viral infections, you've got more secretions that go in, and then bacteria, it's a breeding ground for bacteria. So quite commonly, these people with OA TOF will get secondary bacterial infections on top of their viral infections that they've had. So what do we do? Well, the aim of respiratory management, first of all, is to identify what is causing the respiratory problems. And this is why it's important to see the specialist team, because we can look at all of these things and are trying to tease out what is normal respiratory illness of a child, of a person, and what is more than that. So we want to identify the cause, identify what the problems are, improve daily symptoms. We want to make sure that there is as little symptoms in the daytime as is possible. And we want to reduce long-term impact. This CT scan here shows some scarring, some bronchiectasis there. So this child has developed scarring in their lungs, and this is what we want to avoid by managing it. At the same time, we don't want to overtreat. We don't want to increase the burden of treatment when it's not needed. We don't want to expose people to antibiotics when they're not needed. So trying to get that balance right. We've spoken about the management of malacia already. So management of secretions is really key in this population. And that is with good airway clearance, chest physiotherapy, different ways of doing that, and nebulizers if we need to thin the secretions in order to get them out of the airways. And with infections, good airway clearance, it all comes back to airway clearance, and then antibiotics. And we need to be careful about our antibiotics. We don't want to overtreat, but we don't want to undertreat either. And it's about getting that balance right. We don't need to treat every single cough with antibiotics. As we've heard, lots of children have respiratory illnesses, lots of children have cough. But if that virus, that viral cough, and virus, normal children without OA TOF will have a wet sounding cough. So we can't say, well, it's a wet sounding cough, that means we need to treat it. There's no real way of telling between a viral infection and a bacterial infection. It's very hard. But mostly a virus infection will be associated with a runny nose, things like that. But then a secondary bacterial infection can develop on top of it. So if the cough hasn't gone within a week, certainly within 2 weeks, you'd be thinking a bacterial infection was quite likely and be wanting to treat that with antibiotics. Some children with repeated infections will benefit from having prophylactic antibiotics, and it's about working with that individual child, individual person to work out what is the right treatment for them. So very quickly, in my last couple of minutes, we're going to look at the experience at Alder Hey. So we've put together a database looking at our 20 years of experience. So we have 238 patients on our database who were born between April 2004 and July 2024, so in that 20-year period. Now, when you go back and you're looking at data from 20 years ago, it's not always easy to tease out that data, and we haven't got, it will be an incomplete data set. The records from 20 years ago aren't that complete. We're not going to be able to get everything, but we are going to be able to get more than we have now. So I've said this is our interim analysis data, but I'm sharing it with you for the first time. So here, we've got each year, you can see how many children we were born and managed by in each of the years, which is between 4 people each year up to 21 people in this monster year of 2016. So a big variation between the years. So looking at that, we've got 150 had a primary anastomosis, so where the top end of the esophagus is joined to the bottom end of the esophagus, and that has grouped together at the moment those who had that immediately after birth and those who had that delayed down the line. We'll separate those out in due course, but for now those are grouped together. 9 had an H-type fistula, so you have a connection between the trachea and the esophagus, but you have your esophagus is not, you don't have a gap in the esophagus, you just have that tracheoesophageal fistula, you don't have OA. So 9 patients with that. 33 have a long gap, and again we'll have a look at what we'll go on to have a look at that group in more detail. Currently 46 have incomplete data, so I've got some of those missing out there. So having a little look, in an ideal world, all of our children will have an MLTB. That's where the ENT surgeons have a little look into the airway to assess have they got a cleft in their larynx and have a look for malacia. Only a third of our cohort have had that done. Again, I don't have that data yet. I'm hoping when I look at this in more detail, it will be those 20 years ago that didn't have it done and that our more recent ones have had that done. But again, we're working on that. A quarter of children will have had a CT scan looking for evidence of bronchiectasis or blood vessels. It may be that they've had malacia. We want to make sure where the blood vessels are, that there's nothing pressing on it. So a quarter of children had a CT scan. A third of children have been hospitalised for antibiotics for respiratory infections. That may change because it's quite likely that the ones that I've got more complete data sets on are the ones who have come to respiratory clinic. So when we get this complete data set, it may be that not quite as high as that. The ones that I don't yet have the data on are ones who perhaps don't have respiratory symptoms. These children had between 0 and 24 dilatations. So some, a lot of dilatations, others none. So a real variance there about how many times they've been to theatre to have a dilation of their structure. 31 children diagnosed with tracheomalacia, again, and those are the more severe ones because 8 of those needed some surgical intervention for that. And finally, respiratory is obviously what I do. I'm a respiratory consultant, and this is my first look at how the lung function looks in these different groups. So long gap, the H-type, and then the short gap. That should be labelled those with a primary anastomosis or a delayed primary anastomosis. That group is put together. But we can see here, this is the lung function, the 2 values that we look at. This is the total amount of air that you breathe out, and this is how much air you breathe out in the first second. That's what we look at when we look at lung function, the 2 main things we look at. We can see there that there's a reduction in all groups and that the average is 83%, so a slight reduction compared to normal. To healthy populations, you expect the average to be 100%. That's how it works in lung function. 100% is what you expect. Some will be more, some will be less. So there is a reduction in lung function, 83%, but 61% in those with a long gap. And similarly, when you look at both figures, they're both very much the same. So Natalie's work trying to improve those with the long gap is clearly very important because we are seeing a significant reduction in lung function in that group. And in summary, respiratory complications are common in people with OA TOF, can be hard to differentiate normal childhood illnesses with OA TOF respiratory disease. That's why healthcare professionals experiencing OA TOF are needed. Any management plan should be individualised. Chest physio is time consuming but really important in some people with OA TOF, but we don't want it to be there for everyone who does not need it. And those with long gap may be impacted in terms of reduced lung function. Thank you.